Hello folks, so today we will discuss this new article published in New England Journal of Medicine, that is a randomized trial of drug route in out-of-hospital cardiac arrest. Now in this paper, they looked at the effectiveness of this IO route versus intravenous route and the outcomes in out-of-hospital cardiac arrest, because the effectiveness of drugs such as epinephrine is highly time dependent. The more the later, the effectiveness of epinephrine in cardiac arrest decreases. So this study looked at these clinical outcomes of whether the difference in drug route in emergency situation, particularly in pre-hospital setup, is any different. So it was a multi-center open label and a randomized trial. It took across 11 emergency medical systems in United Kingdom. So patients that they include were the adults with cardiac arrest on whom the vascular access was needed for this drug administration. Now they randomly assigned two groups of patients to receive the treatment from their paramedics, either by this IO first versus IV first access strategy. So the key primary outcome was survival at 30 days, and secondary outcome was any achievement of ROS at any time during the pre-hospital resuscitation. And another outcome, the secondary outcome they looked at, was a favorable neurological function at hospital discharge, and they defined this neurological function at hospital discharge by a score of 3 or less on this modified ranking scale, in which score actually ranges from 0 to 6, with more higher the score that indicates a greater disability. So these three were their outcome variables that they mirrored in this study. So patients, there were total 6,000 plus patients in this randomized study. So and there was usually a 50-50 distribution or randomization, 3,000 plus into IO group and 3,000 plus into IV groups. Mean age was 68 years, with more being men. So this is important that median time from emergency call to drug administration in this study was 24 minutes. So what they looked at 30 days, so nearly this 137 out of 330 in IO group, that actually constitutes 4.5%, and 155 of this group, that's about 5.1% in IV group, were alive. So the 30-day mortality in the both the groups is pretty much same. This 4.5 and 5 point is not a big difference, and that's actually proved by this adjusted odds ratio. It's 95% confidence intervals and p-value, so that is both statistically and clinically insignificant. Second thing that they looked was that at hospital discharge, was there any favorable neurological outcome differed in the group. Again, the results show that it was 2.7% in the IU group and was 2.8% in the IV group, with its no clinical difference in neurological outcomes at hospital discharge between the IO and IV group. So both these results are clinically as well as statistically insignificant. As far as the ROS was concerned, that ROS anytime occurred in nearly 36% in IO group and 39% in IV group. So not a much big difference clinically, and again the statistically there's no difference as well between achievement or ROS in two groups. So there was only one adverse event that was recorded in this intraosseous group, that was mild pannal activity. So these were the outcomes achieved with this study. Okay, the limitations and caveats of this study. First thing, that the researchers did not collect the data on few items like what was the resuscitation quality, because these patients, the data were from the pre-hospital setting, usually by the EMS paramedics, and the routes were usually taken by these people. So researchers don't know that what was the resuscitation quality in pre-hospital setting in these patients. Then those clinicians that provided this pre-hospital care on the route hospital, they were aware this route of delivery, so this is kind of a bias is there. That was a pragmatic study, so many confounders, because usually the EMS studies are being carried on patients that are in real life emergencies. So there are people dealing with these deadly condition, actually dealing with really very uncontrolled environment rather than some controlled studies of stable patients. So there could be many confounders in this study. The thing is that was no difference in results, and there also was no any safety concerns regarding IV versus access. So The bottom line from this study is that you aim for IU or IV, whichever is easy to go. Sometimes you can't just get the IV, so if you think that IV is going to take time and you have the resources and training, just go with the IU, because IU is quickly to achieve. So there's no difference in their outcomes, no any safety concerns. So just go with whatever you can do quickly. Thank you.